maybe the weather will cooperate with us. I don't know. Looks like things are about ready to bud and come out here in Indianapolis. It's still not quite looking that way up north a little further, but anyway, and down south, probably they already have some trees budding out. So anyway, well, good morning, everyone. Uh, I'm hoping we get a quorum, but I'm not sure we'll have one. So the first thing I'm going to do is do a roll call because we cannot proceed with official business unless we have a quorum. So let me just go through that this morning. Okay. Becky, are you on, Becky, on spot? James Goon? Deb Lambert? Jennifer Lance? Stephen McCaffrey? Dan Mustard?
I'm here.
Hi, Dan. How's
Hello.
Columbus?
It's cold.
Okay. Judith Schoon? I know Judith's coming. She let me know that, but she's not here just yet. Katrina is here. Good morning. Thank you. IHCDA is present. Megan Springer. And Kelly is here. Hello. Well, we do not have a quorum, so we cannot, we'll just, does anyone who's here have any comments on the minutes? We had a few revisions here.
I do not, but Jennifer Lance emailed the group saying she can't get in with the link that she has, so I don't. So I just want to let you know that.
Oh, okay. So we're still having technology issues? Apparently.
At least she is having trouble.
Okay, we'll check back a little later and table things. All right. We're pausing just a moment for technical difficulties. Okay, we're going to proceed. We have one person that's having a little difficulty with the link to the meeting. So I'll revisit our role if we need to in a little bit. So, okay. So does anyone here have any comments on the minutes?
I do not.
Okay. Dan? No.
No.
Okay,
I don't.
we will file the minutes and bring them up for approval when we have a quorum at later meetings. Okay, obviously we can't do elections because we don't have a quorum. All right, we have a presentation this morning on the waiver reset. So Holly, if you introduce yourself to the group and we'll proceed with that. Thank you for
very
coming.
much, Dr. Berg. Hi, I'm Holly Wimsatt. I am the Director of the Bureau of Disability Services, and I can attest that we do have green down south in southern Indiana because that's where I'm from, and my grass needs to be cut already. So I don't know how that happened so fast, but it did. So Dr. Berg, you were spot on about that. Thank you for the invite today. Appreciate the commission allowing me to come today and BBA for inviting me to speak. I wanted to talk a little bit about, I think Rebecca's going to run slides, right? Okay, awesome. Thank you. Wanted to talk a little bit and just provide some information about something called waiver reset. And you can go to the next slide, please. The Bureau of Disability Services, or BEADS as we're commonly referred to, currently operates 4 home and community-based Medicaid waivers: the family support, the community integration rehabilitation, the health and wellness, and the traumatic brain injury waivers. We have been operating those waivers, or those waivers has been in existence for quite some time. We have been engaged in a waiver reset initiative, if you will, to really look at how we provide HCBS today and how we can structure our HCBS or Medicaid waivers to address the needs of those we support. So we are planning for cross disability waivers. so that currently individuals who are on the various waivers, what services they have access to on those waivers often depends on diagnosis, their actual diagnosis. And what we have heard from the individuals and families we support is they believe services would be better accessed if they weren't restricted just by, or if their access to services or what services they can access wasn't just limited by their diagnosis. So that's one of the reasons we're going to waiver reset. If we can go to the next slide, please. Some of the goals that we have for waiver reset is, first of all, to simplify the system. That's not a big surprise to anyone that we need to do that. We hear that from a lot of our partners. We hear it from individuals and families that we need to make a waiver system or develop a system that is easier to understand. So that is a goal of our waiver reset. Also, to reduce the number of assessments people have to participate in or endure, as well as reducing some of the paperwork and administrative steps for individuals and families, and also for our partners, our providers, case managers, that sort of thing. And then updating the services that are offered, which is related to what I just spoke about, how today a person's diagnosis can impact what services they're able to access and what services they aren't. We also know that as part of waiver reset, we need to improve support coordination. We can call it support coordination, case management, care coordination, service coordination. But we know that that is a cornerstone of HCBS Medicaid waivers. And we need to do everything we can to enhance how we do that today. That includes understanding how all the different supports available can connect to support the person, and also more support to individuals and families in maximizing unpaid and paid supports, ensuring inclusion and access to those supports in the community that anyone without a disability or without a home and community-based Medicaid waiver has access to. Additionally, we want to enhance quality outcomes. We want providers of services to be ready for any new or updated services that come along with waiver reset. And we want to really focus on outcomes for the individuals we support in every service that we provide. What is the desired outcome of the service, but how is that service supporting that person towards their identified goals? So quality is a huge focus as we move through waiver reset and develop new waivers. Lastly, and certainly not least important, is implementing a sustainable service delivery system. We need to be good stewards, and we need to make sure that in waiver reset, we are building a sustainable system that can continue in the future. Some of the steps that we're taking towards that is we are moving to utilization as part of waiver reset of one assessment that will provide, and that we use today, one set of assessments, I should say, to assess eligibility, and then look at how we can use that same assessment to determine level of need and support needs. That would then feed into, and we'll talk a little bit about this, inform budgets for individuals. So we would set up support budgets with available funding based on an individual's assessed support needs and support level. And that will create a more equitable distribution, if you will, of those funds. We also want to lay the foundation waiver reset to address the growing number of people seeking services and waiting for services. Next slide, please. So our reset engagement timeline. So we began stakeholder engagement in September of last year. I do want to note, we as a division have always seen it as a priority to get stakeholder input and feedback and engage with stakeholders. So I don't want to give the impression that that only started in September, but that targeted stakeholder engagement around waiver reset specifically started in September through December. And on your slides, you can see how many individuals we spoke with. Those happened in large group conversations, small conversations, and even some one-on-one conversations. We connected with a little over 2,200 people. We're in phase 2 of our stakeholder engagement now with the Supports Budget Community Advisory Board, which began in late February was the first meeting. This is a small group of individuals with disabilities, their families, and some of our other stakeholders, some trade associations and advocacy groups. That first meeting took place in late February. The first in-person meeting happened yesterday afternoon. And I got to attend, and it was a very good meeting. We got a lot of great feedback, a lot of great participation. So I'm really excited about that advisory board. Next slide, please.
Can
Oh, yes.
can I ask a question on that, Holly? You talked about who is represented, and I know I attend the DDARS Advisory Council meetings, and so talked about that. Is there representation of that group for the under 60 population with physical disabilities? Okay.
Yes, there is.
Okay, okay.
Yep.
And advocacy?
Both the individual and family members. Yeah.
Okay. Anyone from an advocacy standpoint?
Yes.
Or, okay.
Yes.
Who is that?
We have the ARC on. We have another family association. We have several trade organizations, and a member from IU, from IIDC. Trying to remember who else, Kelly. There's others, but I'm not pulling them all.
Okay.
Okay.
Is that group, is it publicly available? Who is participating in that?
I can share that information.
Okay.
Yeah, I wouldn't share the names of the individuals and families, of course, but yeah,
Okay,
the organizations. Mhm.
great.
So with phase 1, some of the feedback we received, and again, these were these larger group conversations or small group conversations. This was prior to implementation of the support budget advisory board. But some of the things we heard was a desire by our partners for a new waiver structure that addresses mid-level support needs. That individual budgets be based on individual assessed needs rather than a diagnosis. And I kind of talked about that a moment ago. Budget structure to address changing needs of the individual. Continued flexibility to choose a service mix to address those needs. Reimagining of some services. Continued ability to self-direct services. So, it was fairly recently that we were able to roll out the ability for certain services on every one of our waivers to be self-directed. So we've already gotten great feedback on that from individuals and families, and they like that model. So they wanted to make sure that that goes into waiver reset as well. Enhancing telehealth options, and then meaningfully inform and engage community members as decisions are made. So those were some of the high points of the summary from that phase 1 feedback.
Holly, what did they mean by mid-level support?
That's a great question, Dr. Burke. So in the world of the family support waiver and the CIH waiver, so the family support waiver is a capped waiver. So every individual on the family support waiver can utilize up to about $26,000 a year. The community integration and habilitation waiver has a similar structure to what we're going to move to in waiver reset, where individuals have what's called an algo level and then an allocation attached to that algo level. And that's and those budgets tend to be significantly higher than $26,000 a year. And both of those waivers were designed for individuals with intellectual and developmental disabilities. Okay, so what we've heard from a lot of families that work with, or families of individuals with intellectual and developmental disabilities is there needs to be something between those two, right? We hear a lot from families, we don't need much, but we need more than $26,000 a year to fund our services. The mid-level support needs comes in with that particular segment of people that we support. The health and wellness waiver does not, or the TBI waiver, neither of those have any kind of cap today, nor do they have any kind of funding formulation that's formalized like we have with the community integration habilitation waiver, if that makes sense.
So an example of a mid-level need would be what concretely?
Of a mid-level need.
Mhm.
So that could be someone who needs maybe 10, 15 hours a week of support in accessing their community, doing their grocery shopping, perhaps money management. The 26,000 is depending on what services are being accessed. It doesn't stretch as far as some families need it to, right? And when we think about implementing and creating or building a sustainable system, I think one of the keys to that is we have to get to a place where we are supporting individuals and families in accessing those resources that are already out there in the community, and then also building those connections in the community and building those informal supports, as well as looking at other, particularly waiver services and other state plan services as needed.
So there's caps on some of these, not caps on others. So when we have a cap on something, the money is expended for that period of time. People are on their own.
When there is a cap on the family support waiver,
Yeah.
like as an example.
Yeah.
The people on the family support waiver have a variety of needs. We serve about 24,000 people on that waiver, and they have a variety of needs. But that's a capped waiver, so they have a certain amount of funds. Again, the importance of looking at.
My point being, often when we say we have this available in the state,
Mhm.
this is not a criticism of you, but it is only available to those who who can receive the services. If everything's gone, there's a cap on it. It's really not available to everybody. I think we have to be a little careful on how we say what's available and what isn't, because people make the assumption that it's available.
Mhm.
Well, it is, unless you come in after the cap's been reached, and then it's like, well, it isn't available. So, that's all I'm trying to say.
Sure.
Sometimes when we put public messages out there, people misunderstand.
Yeah, and I think it's important to note too, Dr. Burke, that's a great point. The home and community-based Medicaid waivers are something that states can request from our federal partners at CMS, but they're not entitlement programs, which is another key piece.
And people don't understand that.
Right. Right.
Thank you.
Next slide, please. So one of the things that we are doing in Waiver Reset is looking at, as I mentioned, the very diverse way that we people access those waivers today in terms of what funding is available. So as part of Waiver Reset, we're going to establish a budget amount for each person in every support level. That will also take into consideration their age and their living arrangement. Again, that's similar to what we do with the community integration habilitation waiver today. That budget will be derived by calculating a cost of a model service mix, which will be dependent on, a lot on our waiver structure and what services are available. And I want to be clear, the model service mix, the support levels, the support budgets, none of that replaces that person-centered planning and development. It doesn't replace that. when we say a model service mix, that's just kind of, oh, people with this level of need typically would have this type of service or this amount of service, but people will be able to choose what services to address their needs. They won't be locked into a particular service, for example. Next slide. Why are we pursuing support budgets as part of waiver reset? Well, as I just mentioned, there's been a weak relationship between the cost and need on some waivers. We need an improved ability to predict spending. That goes to the sustainability piece. We need our system to be able to accommodate changes, whether that's changes in rates, addition of new services, changes in policies. We also know we have limited resources and increasing demands. Promote sustainability and reduce the service-only orientation. So what that's referring to is, for example, with the family support waiver today, it's a capped waiver, and the approach is sometimes this is how much money you have. What do you want, right? That conversation really should be about what is your need? These are your assessed needs. These are things available, waiver services, other resources. Let's see what we can do to address those needs. Because the waivers and home and community-based services do take into account, as today on our waivers, we have some individuals, they may have access to that $26,000 or 48,000, whatever waiver they're on, depending. Doesn't mean they have to use that. Some people will not choose to use that, right? Some will use less. Some may need more than that. So we have to, that's the beauty, I think, of these support levels and support budgets, is really using that assessment to determine the same assessment with everyone, to determine what level of support a person needs, and then bring in what the funding is available to address at least some of those needs. The support budgets promotes transparency and understandability. Individuals will know post their assessment. They will know what support level they are in and what the corresponding support budget would be. And that can support them and their team while they're planning moving forward on the waiver. The other thing about support budgets is they are not wholly reliant on historical costs. And it's an approximate need and cost of people on the wait list. So as I mentioned, that assessment will be done with everyone. Or depending on their age, there's different assessments depending on the age of the individual. But that will allow us to also know of the people we have on the wait list, what the approximate cost would be once they all have a support level, what the approximate cost would be to work through that wait list. So there's a definite advantage to having that piece of information available. Next slide, please. So what is a support budget framework? Again, it applies to everyone to increase fairness and allow everyone to be supported based on their assessed need. Using a standardized assessment to determine the level of support need. And those are, you'll see that Inter-I. That's the suite of instruments that we use to determine eligibility today for all 4 of our waivers. And that determines, again, that level of care eligibility. The support budget framework also considers other factors related to service offerings and costs besides support needs. So again, age of the person, is the person school age? We serve a lot of youth on the family support waiver. We serve some youth on the health and wellness waiver. The kids are entitled to educational services. So that's a factor, as well as where a person lives, a person living in a family home versus a person living in an apartment with housemates. Those types of things will also be considered when we think about the support level and the support budget. Next slide, please. Wanted to outline here, because I think as we talk about waiver reset, again, we don't want to get the person-centered piece of that lost, right? That's the key here. The most important people in this whole process are the people we're supporting. So what is their experience going to look like post-waiver reset? Well, again, we have already started the assessments with the Inter-I tools. We've been using those tools for the nursing facility level of care for a number of years with the adults. And then we launched some assessments specifically for youth for nursing facility level of care. And then just this calendar year, we launched the use of other Inter-I instruments to assess the ICF IID level of care, which is the level of care required for the family support waiver and the community integration and habilitation waiver. So we're using Inter-I tools across all of our waivers. And those assessments are done initially when someone enters services. And then they're done annually. That's not new. The level of care or eligibility in HCBS Medicaid waiver always has to happen annually. That has been in place, I can say forever, because I was in Indiana when these waivers were born. So forever, that is a requirement. But so the individual will participate in that assessment. And then once that assessment's been done, they will know what their support level is. They will know and have a description of that support level, how that level was determined, again, utilizing that assessment, and then also look at that model service mix and the overall budget for that person. Again, looking also at their support level, their age, their living arrangement, just a very holistic approach to that person. So the individual will know that, and they will have that information in writing to take into their planning meeting. And then they will work with their case manager to select services based on their needs. Again, that may look a little bit like that model service mix, and it may not. It isn't, that model service mix is not prescriptive. It's something to help families and individuals when they're planning. So that's where that person-centered planning piece takes place. Next slide. So this, and please forgive me, I haven't updated the data on the left-hand side, but you can see there the age ranges of people that are in services now and some totals. Again, I needed to update those. My apologies for not getting that done before today. But you can see we have the 4 waivers and then our goals, right? The yellow box talks about waiver case management. So today, the family support waiver and the community integration and habilitation waiver, well, first of all the waivers require case management. The FS and CIH waiver, we have contracted case management organizations that provide that case management. There were 6 of them for the 35,000 people roughly that we're supporting on those 2 waivers. We have recently had waiver amendments out for public comment that closed yesterday, where we are looking to move to selective contracting for case management across all 4 of the waivers. We believe we know from having done the 1915B4 selective contracting for case management on the CIH and FSW, we know that we can enhance how that case management is provided and the experience of individuals and families as they're receiving case management. We can gain some consistency there and better support case managers when we have a selective contracting piece in place. So the plan for that is that the amendments that have been out will go to CMS by the end of April with a planned implementation date of August 1st. So that will include the P4.
Would you anticipate announcing who the new case manager will be?
We anticipate those awards will go out in April, late April. Could slide into early May, just to be honest, but again, that process is still happening with IDOA, so with their guidance. So, but our original goal is to get those out in April. I think it'd be probably late April. And then again, at the end of waiver reset, we'll have a new waiver structure to support individuals with disabilities. And we will, throughout this process, we are working very, very closely with our BBA family and our Office of Medicaid Policy and Planning, or OMPP family, friends family, knowing that in a system as large as ours, right, anything we do could have other impacts in other divisions and agencies. So we are collaborating and talking through all of this. We are partners throughout the whole process, and we'll work together on the policies and the procedures and all of those things to support a coordinated effort. We are being very mindful. I do want to note that even post waiver reset, individuals who are accessing home and community-based services via the nursing facility level of care, those individuals will transition to pathways at that age of 60. So again, that makes that coordination with OMPP really vital, so that we can support people through that transition when they turn 60. Next slide. Please.
Whose responsibility is that transition? Who helps them with that transition as they go from one to another?
Yeah, so that's a shared responsibility. Now the case manager, we have a process today that I'm sure will be updated, right? Where the case manager on the health and wellness waiver, for example, has very clear steps on what they need to be doing to help prepare that person for that transition. There's also work by the enrollment broker as well, but I'm not as current on that because that lives in OMPP. So I'm not as current as on exactly what that looks like, but I'm sure we could get that information or have that presented here. But the case managers start about 6 months or longer ahead of the 60th birthday month to start prepping individuals for that transition. And we will continue that, that again, we may tweak the details and the weeds of how that's done, but that will continue. And we will have contracted case managers too, after August, to help guide those people through that process. So our implementation timeline, January, just a few months ago, I can't believe it's late March, through August of this year, we're gathering data. Now, again, we have data on the inter-I assessments for individuals on the health and wellness and the traumatic brain injury waivers, but we just started using those tools for individuals on the family support and the CIH waiver. So we're going to gather data through August. Again, we're already convening or have convened the support budget advisory committee, and then working with our family over in OMPP, our family and friends in OMPP, on the coordination of state plan services and waiver services. Again, really looking at that from a holistic perspective, not just what waiver services does a person access, but also what state plan services are they also accessing. And then August forward, we'll be doing the data analysis and designing. Continuing engagement with our advisory committee. And then that data is going to inform and design the design of the service mix and the budget framework. And then we'll be, also working on service planning guidance for case managers and individuals and families. The couple key pieces of the implementation is that the assessment, the NTRI assessment, is extremely comprehensive. It also provides by using that assessment, provides a level of objectivity in assessing the need because it is very comprehensive and it is very standardized, right? So everyone's asked the same questions. Everyone starts, with that basic assessment. That assessment is also done every year, again, as I mentioned earlier. So we're really maximizing the use of that tool for eligibility, for identifying assessed need, for service planning, and then we'll be using it post-waiver reset for the resource allocation across all the 4 waivers.
Holly, are there specific data points inside the NTRI that will inform the support budgets and levels? Like,
So the support,
you talked about the living arrangement, like all those
Right.
types of things.
right,
Those,
the age and living arrangement will be also considered, right? But the NTRI, that's a great question. The NTRI tools, as I mentioned, are very comprehensive. So everything in that tool is not used as an example for eligibility, right? But it does inform other areas of need for individuals. It asks about environmental situation. It asks a lot of different questions. Takes about, once you're used to administering it, it takes about 45 minutes. It's pretty extensive. So yes, there are a lot of data points in there that are used to identify the needs, but we're just gathering the data right now. So we'll be working on analyzing that post-August. Next slide. Oh, I did go over. I told Aaron I would probably go over on time, and I did. I'm sorry. Any other questions or?
You talked a lot about the assessment guiding, all of that. Do you take into consideration the geography at all? Like the rural versus urban and the actual setting for it?
Yeah, so I think that's I'm reaching back into my memory to see if that is actually asked as part of the NTRI. And I can't honestly remember. It certainly, we have people's addresses, right? And rural versus
And I also don't know that they would be necessarily aware of what services are nearby to them either.
Right. So
Or
I
none.
do, yeah, it certainly is a consideration in terms of individuals' needs, right? Like what they have access to. We do require for case management that they need to have the area they work in, they need to have regional knowledge of, right? That's in the current model, and that will be in the model going forward as of August. Little hard to hold people to that right now on case managers on the health and wellness and TBI waivers, right? Because we don't have a signed contract with them. Now, I think most of them do that because they're in it to do a good job, right? So I'm sure they do that, but we'll be formalizing that some in the contract because that is a consideration for people, right?
Well, and I think it will increasingly become so with urbanization
Mhm.
and population aging. I mean, I live in a service desert. And my granddaughter, who is 30 years old, there's just nothing up there in Tipton. So there's a lot of Indiana that's rural. So
Mhm. There
always
is.
keeping in mind, it's really difficult in many areas of our state to access services.
Yeah, that's a good question. Maybe we could, in the future, maybe, we monitor providers and where they are in the state. I will say we've got a lot of providers of
Mhm.
services. a lot of providers of services. I think if there's, when we think about capacity, sometimes that capacity isn't the number of providers, but the staff within the providers, right? And the capacity, the other resources, training resources and that sort of thing, that providers have or lack. So, yeah, the rural urban is something that we all deal with in our lives, and then it can be a little more difficult for individuals with disabilities.
Well, whether it's geographical gaps or whether it's caps on services and so forth, that's kind of what I've been saying today. I think we have to be able to communicate with people that even though it's written that we have these services, they're not always available to people due to gaps, due to caps, whatever. And so we have people that don't have access. And I think that's not well known to the general public. They see something, oh, you have this, so it's available to everybody. It isn't. And then in local communities, it's coming very local, a local issue. Local government doesn't have, they don't have the resources to provide services. You get that in your housing. I knew where that question was coming from. Even if there is available housing, in some of these areas, and it's going to increasingly become a problem because of urbanization, because people don't have a way to make a living in rural areas. And so, yet we have a lot of people who are older and a lot of people who have disabilities who are younger in those areas, because housing costs less and they often have families there. Well, there's so much you can do locally, but we don't have infrastructure in local government to take care of it. So this isn't a criticism of what you're doing. It's just saying we need to be sure the messaging is clearer. And that isn't always politically wanted, but I think we have to be honest with people because they don't know. They think, well, if the Bureau of Disability Services in Indiana has these programs, everybody can get them. No, not really.
Well,
Depends because of gaps and caps. That's all I'm saying. They're supposedly available, but you can't do anything about it if it's capped, and you can't do anything about it if there's no service in the area. You do the best you can. But I know my granddaughter, there were services she needed she couldn't get.
yeah, I think it's important too, and this is a whole other, I think, discussion, Dr. Burke and I, is really knowing that there are limited resources, right?
Yeah.
How can we build supports in the community, right? It's about community inclusion, and yes, there are people that will likely always need some sort of form of supports. But how can we get people to really be included in their communities, and have local communities, if not funding, right? But stepping up and ensuring that everyone has a seat at the table in that community and not just individuals without disabilities. So I agree with you. I think, there is a limited pie, if you will. And we got to think outside of that pie too, on where else can we grow and build inclusion. I agree.
Well,
Appreciate
thank
it.
you for your presentation today and for
Thank you.
dealing with our questions, as particularly
Absolutely.
mine. Anyway, thank you so much.
Thank
Holly.
you.
Appreciate it. Thank you for your work. Erin, are you willing to step up here and put up with us today?
Yes. Just a quick note, the emails are coming through. The Jennifer, Stephen, and Deborah are online in the public view.
Yes. Just
Oh.
and because
No.
Dan is on and I can see that you're on, I think there must be something on their end.
Okay, we just request that somebody work on technology for our meetings, please, because they can't participate. But thank you for being here. I kind of thought there'd have to be more questions and input than we were getting, so We're working on it.
There is someone with an 812 number that appears to be in the meeting that I don't know who that is, so that might be a board member, but no one has spoken up. So if you're the 812 number,
I got in with no problem.
and it seems, yes, so I don't know.
Okay.
But today, wanted to share some updates on the Bureau of Better Aging. I'm Erin Wright, the director of the Bureau of Better Aging. With the most recent legislative session, Senate Bill 222 was passed and signed by the governor, and it's now Senate Enrolled Act 222, which was essentially the FSSA Matters bill. And in that bill was the formal creation of the Division of Disability, Aging, and Rehabilitative Services. So effective July 1, the Division of Aging and the Division of Disability and Rehabilitative Services are merging into one agency within FSSA, and the Bureau of Better Aging is formed as a fourth bureau, part of DDARS. So we have been operating as the Bureau of Better Aging and as a part of DDARS since last summer, but it is official in code now. So we are really excited about that. Also in Senate Enrolled Act 222 was language that codifies that the aging and disability resource functions are a duty of the area agencies on aging. We appointed, I guess, for lack of a better word, the ADRCs are designated the ADRCs, the AAAs as our ADRCs 2 decades ago, but there was never anything formalized. So that is now in Indiana code as well. So especially with one, the ADRCs are part of the Older Americans Act, and 2, we currently fund some of the ADRC functions with choice dollars and receive a Medicaid match on those. The choice dollars are statutorily required to go through the AAA. So it just is trying to make that process a little cleaner and smoother for procurement purposes and just clarity. So with the passage of 222 and the formal merger, we have at the BBA been able to really move forward with our reorganization and new team structure. We have been working on really trying to move to a structure that is centered on the people that we serve, the programs and policies that we administer. So we have reorganized ourselves into 3 different teams: a program and policy team, a quality and outcomes team, and a provider and vendor relations team. And just this week, we doubled the size of our leadership team. We brought on a new deputy director, a new director of program and policy, and a new quality and outcomes director. And then Deb Igleski, who has been with the Bureau for almost 5 years. She is serving as our director of provider and vendor relations. So I wanted today to introduce our new members of the leadership team. So I'd like to ask Jade.
Good morning, everyone. I'm Jade Palin. I am the new Deputy Director and Chief of Staff for BBA, and I come with a social service background. Grew up here in the Indianapolis area, but moved to Northwest Indiana and worked at a small nonprofit organization that worked with youth and families and did a lot of juvenile justice work and mental health counseling and that kind of thing. And then in 2015, my family and I moved back here, and I've been serving the state of Indiana as the Chief of Staff at the Indiana Criminal Justice Institute since starting there. So been in state government for a while, actually started my career at the Department of Child Services many, many moons ago. I won't tell you how long because I'm old, but right out of college and then moved around. So I'm happy to be here. I'm excited to kind of get back to my roots and get back to social service kind of work. So I'm looking forward to working with everyone, and I'm happy to take any questions if anybody has anything, or hit me up after the meeting.
Welcome.
Thanks.
Thank
Thanks,
you.
My name is Kelly Duncan. I'm Director of Outcomes and Policy. And my background is in healthcare populations under Medicaid state and federal funding programs. I'm sort of a Weinberg there. And my role is to help really provide visibility within the programs and the people that we serve, and the outcomes that we are having, and where we can leverage opportunities to make a bigger impact. And to your point, talking about gaps and caps and what that really means to our system, and where we can use those dollars more effectively because they are so limited. So again, my name is Kelly, and I'm working under Erin at BBA.
Welcome, Kelly.
Thank you. I really look forward to working with you all.
Great.
Good morning, Mike Lusky.
Yeah,
As
if you
Erin
could-
said,
So they
I've
can,
been part of the BBA for almost 5 years now. It'll be 5 years in June. The end of June. Many of you in the room know me. The commission may not, commission members, but I very much look forward to serving in this expanded role and doing several of the functions that we need to do now as a result of the ACL new rule, which have also been rolled into the team. So it's going to be an exciting ride and a fun ride. And I am looking forward to providing more support to our vendors. So,
well, that'll
Some of
make a
them are in
number
the
of
room.
people very happy.
yes, I agree.
Thank you so much. Welcome.
Thank you all. We are thrilled to have them part of our team. Our program and policy director, Latasha Hayes, had a pre-planned vacation today and tomorrow, so she's not able to be here, but sure I will be able to introduce you to her in an upcoming meeting. Wanted to share our new organizational chart. I know that it is hard
Are
to
you gonna get that?
Yes, I'll send the slides afterwards.
Okay.
But it really highlights, we have our program and policy at the center, and provider and vendor relations and quality and outcomes are kind of wrapping around. And Jade and Vanessa Convard, our Director of Policy and Strategic Initiatives, and I are really here kind of supporting and helping the team as we move forward in as our new bureau and part of DDARS. So I'm really excited for the increased knowledge and enthusiasm and capacity that we have on the team now.
So is there still an FSSA and then you guys are gonna meet that, or will that take over?
Oh, so there's FSSA, and then the Division of Disability, Aging, and Rehabilitative Services is a division under FSSA, along with Division of Mental Health and Addiction, Medicaid, DFR, 211, OE CASL. I think I'm missing a couple other ones. And then we are one of 4 bureaus under DDARS. So Holly is the director of Bureau of Disability Services. There is a Bureau of Vocational Rehab Rehabilitative Services, and then the First Steps program, the Bureau of Child Development Services. So now DDARS encompasses birth through the older population. Several just programmatic updates I wanted to share. We have talked about the Yellow Dot program that was passed in legislation last year, and thanks to support from I4A and AARP, that program has launched. We now actually have a website dedicated to the program, and I'll be sharing the link. This is just a screenshot of the website, but there's now information out there for the public on the program. So just another way we're trying to spread the word and highlight the availability of the program. We also recently updated our website to include information on the Dementia Care Specialist Program, which is the next slide. There's a whole section now outlined or out. I lost my word, out there. That highlights information on the program and actually also has the contact information for the dementia outreach specialists at all of the AAAs. Again, this is just a screenshot, but that is there for the public to be able to access.
A question on
Yes.
that. So the Dementia Care Specialist Program is continuing to reside within
Yes.
the BBA.
Yes.
Okay.
At
What
this
hap-
time, as far as we know.
You wonder what I would do.
So the legislation
Mhm.
of the last session did not change anything as far as the relationship with the Indiana Department of Health. And
It did not. So there was legislation just passed that adds a focus on dementia and Alzheimer's for the Indiana Department of Health. Obviously, as the Bureau of Better Aging, issues related to dementia and Alzheimer's very much are part of the work that we do, the services that we offer, the people that we serve. So we have had conversations both with the Alzheimer's Association and the Department of Health about this new legislation and how we can move forward collaboratively with, the Department of Health, at least this is in my mind, has a more broad public awareness angle. And the dementia outreach specialist through the Dementia Care Specialist Program can really be the boots on the ground, generating the information sharing and education at the community level. So kind of taking the broad state and then bringing it down to local communities. The dementia strategic plan, which is in Indiana code as a responsibility of the BBA and DDARS, is also ongoing, and work has been continuing on that, and that feeds into all of this as well.
okay, well, that's helpful. I mean, part of our problem is the way we're structured in the state with the Department of Health over here and FSSA over here, and yet you have to work together or you don't have health.
So with the change in administration, we are now part of a vertical that has Department of Health, FSSA, Veterans Affairs. And we have a cabinet level secretary that oversees the Department of Health and Family Services. So we are now in the same, I'm going like this, vertical, because it's on an org chart.
All right.
So I'm hoping as we move forward and try to navigate this, being part of that same vertical will support our collaboration.
That would be Dr. Council and I talking about that, saying, this makes no sense. Okay. All right. I hope he doesn't mind. I brought his name in, but anyway.
Oh, well, I'll
That
keep it- I'll
happens
keep
a
his
lot.
name in the Conversation then. I had a really great conversation with Dr. Council about a week and a half ago about the work he's doing with the managed care entities
Mhm.
on dementia care and case management services and those types of things. It might, I mean, I know he's on limited availability. It might be a great idea if he would be open to a future meeting coming and talking about that work.
Mhm.
Oh, that would be wonderful.
And I know today we're going to talk a little bit about some of the questions that you raised about the caregiver assessment and evaluating caregivers. And a component of that is what are the MCEs doing in OMPP will be at our next meeting. So I had that thought as well, that maybe when we have that conversation, we can also tie in the DSNP
Yep.
conversation
Yeah.
about that as well. So,
It's good stuff. Yeah.
Do you have that legislation already in line where you want to put the departments in order?
it has at least, I don't know if there was any legislation that passed, but at least organizationally, that's how we've been structured since the Braun administration.
So you said that you had some legislation that you were working on. To put all this in order.
So the legislation was for the merger of the Division of Aging and the Division of Disability and Rehabilitative Services into one Division of Disability, Aging and Rehabilitative Services. But we still are under the Family and Social Services Administration, which is part of the Health and Family Services, thank you, Association, which then reports into the governor. And I will, in follow-up, I'll send the link to where the vertical org chart is explained. There's a lot of columns in little font, so, okay. At our last meeting, we talked about the legislation that was passed last year related to the study and preparation of a report containing recommendations for realigning and consolidating the AAA map, or really the planning and service areas. On the next slide is the timeline for doing so. Our goal is to, in 2026, write the report and with recommendations, and if there are changes included, what the new funding formula would be to distribute funds to each of the different regions. So I was hoping to have some time today to talk with you about, as we are thinking about this and as we are moving forward with looking at the study or the report and trying to decide what components are really important for us to consider as we move forward in the creation of this report. I wanted to hear from you what ideas you have for things that are important to consider as we move forward with this process. Because the study is just step one in the process. There are federal processes we have to follow to change the funding formula, change the map. There are state processes we have to follow, including holding an in-person public hearing in each impacted county. So we have 92 counties. So there's a lot before we would even get to the point of making changes. But our focus for this year is the report with recommendations of the funding formula. Thank you. So as we've had conversations, these are some high-level areas that we thought were important to consider as we're looking at the planning and service areas. The planning and service areas are designed based on counties. So we need to be looking at things from a county level. I will say, when we get to if we're making changes and we get to the point that we are looking to designate organizations to serve as the area agencies on aging, in federal statute, we have to give the right of first refusal to organizations of local government. So that is a component of this as we're thinking about this is what the PSA may look like, and here's how we're going to fund it. There's that local government can first say, I want to do this. So, and that's in the federal statute, federal law.
That was just I'm sorry, my face shows everything I'm thinking, so go ahead.
Mine does too.
Sorry, but if we suggest that Marion County and Hamilton County are one region. Okay, never mind, sorry. Hamilton County could offer to take both, or like where are we on that? Or would they break up the region?
It would, I think, break up the region because it would be the region for the local government. I will add a caveat that there is the right of first refusal, but there also would have to be the ability to demonstrate that the unit of local government could serve as the AAA and meet all of the requirements. So it's part of the, but there's also it's not a willy-nilly, oh, I want to do it. But they would have to have the opportunity to demonstrate that they could. That's in the Federal Older Americans Act, which is up for reauthorization.
And what is the notification process for those local governments? I mean, are they aware that this is happening? Like how?
So we're not that far
Yes.
along in the process. The way that it's outlined in our policy, and since I've been here, we have only had a change in a AAA once when we so when we were looking for a new planning and service, a new AAA to serve the Area 9 planning and service area, we sent out a public notice to a very long list of units of local government in the area and said, hey, there's this opportunity. It was worded differently, but
Yeah,
here,
sure.
do you want to do this? Are you
Okay, so
interested?
some type of public notice.
Yes,
Okay.
public notice. Yes.
Requirements.
Yes, it's federal code, so it's hundreds of pages, but share that. There's federal code, there's state code. Mhm.
Just don't want to be stupid and go, oh, I want to do this.
Yes. Yes.
Currently, we only have, I don't even know how to word this. We only have one. Is it Vincennes? It's the
Yes.
only one that's under a government
Yes,
entity.
the rest are private nonprofits.
Yeah, okay.
So as we're formulating this study and the questions that we're hoping to address through the study, we've talked about looking at everything from demographics, access to services, where are there naturally aligned communities or counties that, may not make sense to be in different service areas. Are there opportunities for alignment with existing regions for other programs? There is language in the Older Americans Act about considering alignment with the workforce development region. So that's specifically outlined in the federal statute. Looking at administrative efficiency, sustainability. Obviously, these are all very, very broad considerations, but these are sort of the topic areas that we've come up with so far. And I just wanted to ask if there's anything that we're missing, anything that we should add, anything that's really not important to this conversation.
Well, about 20 years ago, I did a sabbatical in South Korea because I wanted to go to Asia and I had some funding to go over and do a study of population aging and urbanization in South Korea. And when you think of population aging and urbanization together, I came back and I thought Indiana is really going to be experiencing this. And that's what I'm seeing over the past 20 years. That's why I talked about gaps and caps. Because what we're seeing is we have a lot of rural areas now that have a very high population of older people in them and very, very little service. And that's what was happening in South Korea. The working folks were in urban areas. their parents were out in rural areas. There weren't even schools in a lot of those rural areas because there was no jobs. People moved. It was the older people living there. But then when they needed assistance, there wasn't anybody there to help them. Of course, they didn't want to move to the cities with their kids, but it's an issue. And so as we think about how we're going to restructure the AAAs in Indiana, I think it's really, really, really important as we think about what's going to guide this, of how we stay in touch with what's actually happening at a local level. Because right now, one of the things that the AAAs have done is they've been more connected with local communities. And as we make larger service areas, we will lose touch with what's going on in those local areas. And it's really an issue. So, I mean, I don't have an answer here. I saw a lot of problems when I was looking at this in Asia, and we're having the same problems here. So we either have to figure out a way to help older people move, structure some policies that will help them move nearer to their adult children, excuse me, I use my language a little better than this, or it's an issue. And I just worry a little bit about, will we get so far removed from where a lot of the population is that needs assistance? And how are we communicating with families? One of the other things I realize in some of the work I've been doing some work that has made me take a look at what research is guiding some of our decisions on some of these things. And at this point in time, research is moving away from linear individual focus to more of an ecosystems focus. And that's why I'm saying, let's look not just that one of the problems with person-centered is it's kind of linear focused, individual focused, and that's fine, except everybody is in a system and the system impacts the person. So whatever we're doing here, I'm going to suggest we get more of an ecosystems perspective in here from research that could guide some of this. Some of that is in the scholarly literature, but I'm really saying let's look at some evidence-based practices that are more ecosystems focused than individually focused as we kind of look at this to guide some of what we're doing. Because if we lose touch with the local communities, we're going to miss a lot. And that's our gaps and caps problem. And so let's look at ecosystems. Let's look at some of the research that's more current that is going to be more ecosystems focused, because this is really an important step. And, I think about local governments, my goodness, they don't have funding now to hardly fix roads, let alone take care of a lot of older people. So we're not going to cut our way out of this problem, even though that's kind of popular right now because people don't want to pay taxes. But we need to carefully think about how we're doing this. So that's why I'm kind of saying, let's go to evidence-based ecosystems and look at some of that and see what it can say. I'm not saying we'll get a lot of answers there, but we can't just think individually anymore. We've moved beyond that with our research. And I'm working with some people in the School of Public Health at IU who are more into the ecosystems place. But let's go and ask some questions here and see if they can give us some help with some of this. I mean, that's publicly funded too, so let's let our researchers help us a little bit with this. This is really an important issue because we are a state where 1 out of 5 people in this state is all 65 and over, or we're about there. That's a lot of people. And not everybody has private funding to take care of everything. So, and talk to local government. They don't have it either. and nobody wants to pay taxes. So this isn't going to work. We're going to have to sit down, scratch our heads and figure out what we're going to do with people, because we can't put old people in jails, and we don't have any place in local government. Local government has no funding to take care of this. So we can't kick the can down the road much longer. But let's go to evidence-based ecosystems and see what we may get with that.
Is it AAA advisory council?
Yes. And
So that's what they would like to see, is that not only do they have the advisory council, but they have at least one person in every community in that council. So if we have 92 counties, let's make sure those councils have people from everywhere that can bring all that information to them, because they're not going to be able to, even today, even though it's 16 of them, they still don't have the ability to be from every community. So if they have the advisory council where they have somebody from every community and their problem, then that helps them.
Is there a way to think about, I don't know how to quantify this, but the AAAs, at least from my perspective, have done a lot of reinventing of themselves over the years, right? And looking at new and innovative ways of delivering care. And so is there a way to look at some of the innovations that some of these AAAs have implemented as a consideration? I think of SEQOA and the community health worker program. I think of Area 3 and their PACE and all of the work that they do there. Like, is there a way in this study to just think broadly about the impact of this restructure for some of these programs that the AAAs have built,
mhm.
and give them the opportunity to expand those as part of this?
I do want to mention that a core tenet of the Older Americans Act really is responding to local community needs. So however we move forward in this, we're going to have to definitely make a concerted effort to not lose that local presence, local expertise, local. So what that's going to look like, I don't know. But that can't not be part of this process. We're really, if you said people don't want to pay, we're not going to cut our way. So
I'm sure I'm the oldest person in this room. I have no doubt. We don't need to do a contest, but I think I win. But I do remember when I started nursing school in Cincinnati, just before Medicare, Medicaid, and the Older Americans Act was passed, because they started down there in 1963. I saw the people coming into the clinics who had no money to care for themselves. I never want to see older people looking like that again. And we just don't have a memory here of what it was like before we had these services. And it's easy to run on, oh, I'll cut your taxes. But what's the other side of that? And that's what people aren't understanding. And that was ugly and awful and horrible. And I really worry about this getting efficient. That just is kind of a code word for we're going to cut. And we can reallocate tax money. Other things we could do other than just cutting. We have cut services to our social safety net, to education, and to healthcare in this country. And we've reallocated tax money to other things. But it's going to really hurt our population. They don't know it yet, but it was very ugly before we had our AAAs and before we had Medicare and Medicaid. And so it was real hard to get old. And people don't remember that yet. I think that's why I said I'm old enough to remember it, but it concerns me with what we're doing. And like I said, I went to Asia to take a look at what they're doing. It's one thing our families don't even understand really what the impact's going to be. They still think they can drop grandma off at the nursing home and apply for Medicaid and all will be well. They don't know it yet. And so I'm real worried about how we message things too. These caps and gaps, we need to let the people know. The politicians aren't going to do it. But we're going to have to be clear with people because they yell at the providers. Well, the providers can't do anything about it. They don't have any, the state, when you're running programs, if you don't have anything, you can't provide it. Now, there's certain things we can do in local communities to help people. We're all going to have to roll up our sleeves and do things differently. But we need to help people understand that it is not the way it was. And so, and that's all I'm saying, but I'm really quite concerned about how we're going to go about this. This is really important. And the work you're doing with the Bureau of Better Aging, this is really important work. And I looked at our statute again, that put the Commission on Aging into existence. And we have some important work to do. So that's my soapbox for the day.
Okay.
Thank you.
Look at the other side, communities have gotten so used to having Medicaid and Medicare and everything and being supported and being taken care of. They're not making their own plans. So not only do we need to protect those that are older, but we also need to get some education to the younger group saying, listen, we're not paying for everything. There are gaps. There are problems. We can't pay for everything. They need to learn that too. You can't just sit back and pay for everything. You just can't. No matter how we try.
But we need to have the discussion so people aren't saying, oh, well, it's all there. It isn't all there. And it's not going to be all there.
Just like you said, they off to the nursing home and they're off and gone. Well, you can't do that. But people have that knowledge and that's all they know.
I understand.
There needs to be some more education for the younger coming into the system, saying, you know what, we can't afford to pay. You need to help yourself.
And some can't. Can't, won't, don't. But we always have those folks, and a lot of them can't. So we got that too. So we haven't figured it all out yet. But what we're doing is, well,
Medicaid plan the other day. It's about my mind. She will hide, honest to God, she hides money, she hides stuff, so Medicaid can't find it, and then they qualify for Medicaid.
well, we've had all these problems for a long time, including the lookbacks and Medicaid planning and who's transferring wealth. Medicaid was never set up to be a transfer of wealth vehicle, but it became that way for the middle class because we could have done Medicare so that we covered long-term care. We chose not to do that. Then we used Medicaid. Then Medicaid became a transfer for the middle class, and the middle class started using Medicaid when it was really set up for those who couldn't work, didn't have it, didn't whatever in the lower socioeconomic class. Well, here we are. And it's time to roll up our sleeves and figure out how we're going to get through this. There's one thing that is for sure, unless something happens that kills off a lot of older people, we're going to have population aging with us for a good 30 years yet. So then we'll even out a little bit with cohorts, but now we got it. And you're right, we got to figure out what we're going to do. And that's why we have the Bureau of Better Aging to help us, and a multi-sector plan on aging. And we'll talk about all of that in a minute and what we're going to do with it. But the AAAs are really important. And I don't know what we're going to do with the AAAs right now, but we need to really think hard about what's happening in the state. Just taking them down to a lower number and diluting what's going on is not going to solve our problem, is what I'm saying. We have a lot of older people out there with needs. And we got a lot of education to do.
I do not, so I will.
And that's going to be really important too, because if we can structure that correctly, we can get to people and make people understand that there is another way besides Medicare and Medicaid to pay for their long-term care. You know, that's what we need to do.
They don't want to.
We don't want to pay for everything either. We can't do that. So something's gonna have to happen.
You're right.
Okay. Thank you for that.
Well, did you get what you wanted? You did.
I did. Okay. So Kelly Tungate had raised some questions, I think as part of the work you're doing with the commission's subcommittee on caregiving, around caregiver assessments, what tools are being used. In February, we transitioned from a case management system called CAMS, which had launched in 2019, replacing a 20-year-old system called Insight. We consolidated the non-waiver and pre-waiver work that was done in CAMS into the portal used by BEADS for the H&W waiver, actually all of their waivers. And so now we are operating in a single system. We did have a caregiver assessment in CAMS. It is not yet available in the portal. We had a very short timeline to transition everything. So incorporating a caregiver assessment into the portal is on our list. There is not one in there currently. I have shared the questions that were on the existing caregiver assessment that was in CAMS, and I'll actually attach the assessment in the follow-up email, but it was 4 pages. It didn't really fit, but it really was looking at everything from what are you doing? Are you working outside the home? Assessing caregiver stress, caregiver burnout, caregiver health. We at the state had not gotten to a place where we were regularly utilizing this information at a macro level. It's there, we still have access to it, but it's not something that we have utilized. The AAAs were utilizing the assessment in their conversations with the options counseling and service planning for caregivers. So it helps to inform those conversations, but it has long been a goal of ours. And as Pathways was launching, there was a lot of conversation around a standardized caregiver assessment, which was not this assessment that was already existing in CAMS. So I think there's still some work to be done in this area. This is the current status.
So is the one that was in CAMS the one that was created at the time by, okay.
No,
Okay.
it was an older tool that had carried over from
Okay.
the 20-year-old Insight system.
Okay. Okay.
And I am not sure how much overlap there is between what was ultimately settled on and the one that was in CAMS.
Okay, okay.
I just don't remember that detail off the top of my head.
Do you know if the managed care entities, as Holly was talking about, are using that tool that was created by Dr. Unruh?
I don't know if it's that particular.
Okay.
Dr. Council would definitely know more, but I know that there's definitely a discussion about standardizing that.
Okay.
Yes. Okay. But I'm hoping at our next meeting, when OMPP is here and if Dr. Council can join, we can have a more robust conversation.
Okay.
Yeah, I
particularly
think
on
we
the
need
Pathways
to,
side.
and with the MCI, I may not, or MC, I may not be saying this correctly because I'm not sure how to say it, but we have bids out now for new contracts for the MC.
The health plans, for managed care health plans.
Yeah, so,
The RFI. The RFI is out right now.
so is there anything in that would require anything with caregiver assessments with the new things that are coming out, or are we just still
The RFI that's out now is for information gathering.
But I guess I'm thinking
then
about our
down
thinking. Are we
the
seeing this as something that
For the caregiver. With the caregiver.
well, I think we should take a look at that. It's been a problem in the state for a while. We've been kind of lacking in the supporting family caregivers. If that should be part of what I'm suggesting, we should take a look at making that part of what they should be required to do.
It was very, it was very prominent, the call out to supporting and assessing and supporting family caregivers in the RFP for the first transition. We're very hopeful that it will be prominent in the next RFP. that's
I'm a
issued.
little more than saying hopeful. I think it should be. I think we're nudging, because otherwise we're going backwards again. Let's look at what evidence-based practices say and research says. And we're counting, if we can't afford to take care of everybody with formal caregiving and we're going to expect family caregivers to do more of it, then we need to be sure that that's part of what.
Save that comment for OMPP in the next meeting.
If I forget, would somebody please nudge me, stab me a little, say spear and say, I mean, it really, yeah, it should be part of that. I mean,
So more to.
Thank
I
you.
just wanted to provide.
Thank you.
Thank you.
And I'll share the tool. So, and I think the only other thing I wanted to mention is there should be a little graphic there.
save the date.
The next FSSA quarterly financial review is August 28th. It's a Tuesday. I am not sure yet what time DDARS is scheduled, but that is coming up where we'll provide an overview on all things DDARS and our financials, and then all of the other divisions go as well within FSSA, and then the secretary generally provides an update as well.
So nothing between now and August.
Did I say August?
You said
You
August.
said August.
April.
Okay.
I thought that was sort of.
Okay.
I'm
Okay. Don't
Okay.
take summer away from
April 28th. Okay. All right, thank you.
Thank you.
Thank you, Erin. Wow. All right. I sent something out, a little memo out to commissioners, talking about our committees or advisory committees for the commission. And I just want to go back and read by statute what the role of the Commission on Aging is to be by state statute. The commission shall do the following. One, and I'm going to use their language, but it's a little outdated, but number one, encourage the study and discussion of the problems of the aging and aged. Number two, promote the organization of and officially recognize voluntary councils for the study and discussion of problems of the aging and aged. And three, assess the division in the development of a comprehensive plan to meet the needs of the aged. I see our advisory committees as being the case in the role of these councils, voluntary councils. So on some of our committees, we've had commissioners on the committees, and some of them, and we have people on the committees that aren't commissioners. So it's kind of a way we extend our reach across the state. And I've really been trying to be sure we work collaboratively with the BBA and the AAAs, because they're all together. That's part of the Older Americans Act. Everything's together there. And as we talked today, there's a lot of things happening and a lot to look at. So one of the things I asked in our and what I sent out in our memo was do we want to change any of the structure of our committees, leave them as is, maybe put some of them together? And that I'm struggling today because we've got some people on our commission that can't talk to us because we don't have the link. They don't have the link. So we may have to make final decisions, kind of wait till we can have everybody talking to us. And one of the things I recommended was in the Living Longer, Living Better Collaborative, that committee, that we work with I've talked with Erin and some of her team about us taking on some work with them on the multi-sector plan on aging. There was a lot of work done on that the last few years. And some of what I'd done with that Living Longer, Living Better, I'm kind of thinking maybe we could kind of change that over to the multi-sector plan on aging, working with Erin and her team, Vanessa Conrad on that, and see what we can do locally. Tina McIntosh is here today. Tina worked a lot on that. Which area of there were like 4 of them.
It was, change the perception of aging.
Reframing aging.
There were so many different names. Reframing aging.
And I've talked with Tina about, since I'm chair, you're still leaving me on as chair until I'm still elected chair, I guess, of the commission. So I wanted someone else to chair it. And Tina has worked a lot with that multi-sector plan on aging and said she would chair it, which I asked her to come today. So I was very happy she came. And would kind of suggest we can't take a vote on it. We don't have enough quorum to do it, but that we change this committee. Yeah, well. But we're going to kind of put forward that this is changed to the multi-sector plan on aging, and we'll support that. And Tina's going to be my chair for that. And please send comments to me about that if you're in support of that. Now, my next question is for these other committees. Do we want to roll some of those in with the work we'd be doing with the multi-sector plan on aging, or keep them as standalone committees? So, okay, you'd like to keep the shared decision-making going. Deb, we can't hear you today, so we'll kind of just let these, and family caregiving, we're doing a lot of things on that. Emergency housing, we can't hear from Deb, and housing supports. I'm not sure where Dan would be with that. Are you
I
on,
would
Dan?
Yeah, I am. I would support rolling that into, part of it is because there are several groups already in the state that are, kind of looking at this, and as the housing committee would meet, what we found was that someone would say, well, this group is working on that, so we need to contact them. And it kind of kept getting bigger and bigger as we were trying to figure out who was doing what. So I think bringing it under an umbrella that has a little bit better, 30,000 feet view of what's going on would be really helpful.
Okay, so we'll roll that in with the multi-sector plan on aging work. Okay, Dan, thank you.
Mhm.
Family caregiving, we're going to leave
I
standalone.
believe standalone. As I look at the framework for multi-sector plan on aging, and I'm happy to join Tina and participate in that group. I think it does, of course, it fits in some ways under the framework, but I think the work is too important to fold that
Okay.
up in there.
All right. Deb, we can't hear from you unless you sent me something. Don't see it just now. We'll let that stand alone for now with emergency housing. And Judith, you want yours to stand alone? Okay. All right. So it's just Deb will need to hear about if she wants to keep that as is. We'll leave them as is for now. But,
Except for
Tina-
housing,
what?
except for housing, right?
Except for housing,
Yeah.
yes. Tina, welcome. Uh, I want to invite all commissioners to be part of any of these committees. It's like we work between the meetings is kind of what we're doing. And so Tina will be working with, I will work closely with Tina. We'll work with, I can't see people. I can't stand this. We'll work with Vanessa. Right? Okay. The this is the old professor in me. If I can't see people, I can't stand it. I was trying to see Erin and I couldn't see her. This is really important. I'm not sure where all this will go. There was a lot of work done on that multi-sector plan on aging. Now, if I'm correct, Governor Braun did support this. You want to talk to that a little bit and I'll sit down.
Yes. So the multi-sector plan initially was approved under the Holcomb administration. With the transition, we presented the plan and received approval for the plan and support for the plan from the governor's office. So Vanessa has been in conversations with AARP. They were instrumental in helping to draft the plan as well, and is working on a plan for next steps to really have the MPA be at the forefront of the work that the Bureau is doing as we're moving forward. So more to come.
Okay, thank you. And I also am hopeful. Gee, I've talked a lot today. I also am hopeful that we can get through this committee some information about what's going on across the state that's innovative with some of the things you're talking about. What's innovating, what's going on educationally across the state. And I'm just going to say this. My hope is we get our annual conference on aging back. We used to have one. Then it kind of went away. I hope that's coming back. And I'm hoping, and we want to work with the AAAs. If we ever step on the toe of a AAA with somebody, please let us know. We want to work with you and with what's going on across the state to try to bring that together. And I hope we can share ideas at something like an annual conference on aging.
We are planning the conference for October.
So that's kind of the hope.
Yeah.
During the committee meeting next week.
Is that here?
Going to be here.
So I want to be sure the AAAs are involved in that. And we will, again, some of the ways we can find out what's happening locally is to, hear from the AAAs. And because we get very concentrated sometimes here in central Indiana, and there's things going on all across the state we need to know about. So really trying to reach out. Okay, that is what I had. Anything else on the advisory committees? Okay. Dan, did you have information on the Senior Center Coalition that you could share?
Yes, our annual conference is being planned for September 17th. And coincidentally, it is in Tipton, not because that is Dr. Burke's home. It is centrally located and it works out really well. We have a space there that works, and we can be out of Indianapolis. Again, part of our theory was that so often everything revolves around Indianapolis, but moving it into a little bit more rural area, I think also kind of sends a message that there are things happening all over the state, not just in Indianapolis. So that will be the other piece of that that we're hopeful is that we might be able to expand it and include participants from a couple of neighboring states. That is a plan that we have right now. So to kind of bring senior centers together and get information that crosses state lines, because each state is very different in the way that it approaches funding for senior centers in particular. But honestly, even within Indiana, the variety of funding is really broad. So many senior centers operate under Parks and Recreation and local communities. They might operate under a combination of city, county. Some could be funded through AAAs. Others, like Millrace Center, where I work, are privately funded, and we don't really get any public funding. So, everybody's a little bit different in how we operate. So also seeing how they operate in other states, I think would be really helpful to us, so that we can kind of share best practices, not only across the state, but across state lines.
Did we lose sound?
No, I'm done.
Okay.
That was it.
Just finished.
Okay. All right. Thank you, Dan. Anna, let's hear about what the AAAs are up to.
Yes, so I'm Hannah Carlock. I am with the Indiana Association of Area Agencies on Aging. Just earlier this week, some of the AAAs and myself were in Washington, D.C. for the U.S. Aging Policy Summit. And we were able to do some Hill visits with Senator Young, Congressman Yakam, Mervan, Messmer, and Shreve, as well as staffers for Congresswoman Houchin and Senator Banks. And we discussed the need to reauthorize the Older Americans Act and increase the funding for the Older Americans Act. So that was our major ask for them, because without the Older Americans Act, we really don't have AAA. So we need to maintain the reauthorization of that, as well as funding. A lot of our AAAs across the state are community partners in the GROW initiative, and they're participating in committee meetings for the usage of the rural health grant dollars that came from the One Big Beautiful Bill last summer. And then, as Aaron said, the Yellow Dot page is now active on the FSSA website. So we will be sending out a release through Representative Arrington's office, and she authored the bill last year, just making sure that everybody is now aware of the Yellow Dot program, and all area agencies on aging, as well as B&B locations, should have their Yellow Dot packets by now. So definitely want to thank AARP, FSSA, BMV, AAAs, first responders for all of their work on getting this program up and running. The legislative session adjourned at the end of February. Some of the bills to highlight are House Bill, House Enrolled Act, actually, since it's been signed into law, 1001, which is the housing bill. So that is supposed to cut red tape at the local government level to get rid of some of the fees that are incurred while developing housing projects, to hopefully pass along the savings to either the homeowner or the leaser. However, local governments are allowed to opt out of that by November. And then House Enrolled Act 1002 is the utility rates bill. So this allows for levelized billing. So that spreads out your bill evenly across the year to hopefully allow people to better budget for themselves. It also establishes the state utility assistance program, waiting on that to hopefully be funded next year during the budget session. It prevents power shutoffs when it is 95 degrees or hotter. So we have the preventative power shutoff for cold temperatures, but not hot temperatures. So this new law allows for that. And it also updates how the utility companies can raise their rates. So it does make it a little bit more difficult for them to raise rates. They have to provide more information and provide 3 years out what that's going to look like for the end user. As Dr. Brooke brought up, House Enrolled Act 1029 is the Alzheimer's and Dementia Bill. So that is through the Department of Health. So we have already made outreach to them, as well as the Alzheimer's Association, of how our dementia care specialists within the AAAs can be a good partner for that. House Enrolled Act 1277, that is, creates an assisted living Medicaid waiver. It also caps the cost on home and community-based services, so they can't exceed that institutional and nursing home level of care cost. And it moves an individual to a fee for service instead of the Pathways program if they're in a nursing facility for 100 days or more. It also has assisted living residents can choose their care coordinator either through their assisted living location or through a managed care organization. And it establishes a study of the home health reimbursement rate. Senate Enrolled Act 1 does provide stricter eligibility requirements for SNAP as well as what you can purchase utilizing the SNAP program. And it also establishes the reporting requirements of undocumented individuals to Homeland Security when they are applying for the SNAP program. And there is increased oversight around Medicaid to eliminate duplicative enrollments. So there was noticed that some people were enrolled not only in Medicaid here in Indiana, but in other states. So they're trying to tighten all of that up. And then as Kelly mentioned, the RFI, the request for information, is now out for I guess you could call it the mother of all procurements, as Secretary Rove refers to. So this is around all of the managed care entities. So that's HIP, Hoosier HealthWise, Hoosier Care Connect, and Pathways. So that's serving over 1.4 million Hoosiers and has a roughly $68 billion price tag on it. So that request for information is out and is due back April 15th to Department of Administration. And that's my update. I'm happy to take any questions.
Thank you, Hannah. I do have a question. What are we doing with the assisted living waiver? Don't we have one? What's this legislation kind of? That's probably not your question. It's more. Thank you, Hannah.
So we don't currently have a separate assisted living waiver. Assisted living is a service covered under the Pathways waiver and the health and wellness waiver. With this new legislation, FSSA needs to apply for a separate waiver for assisted living. I can't remember when the deadline is, but I believe it's sometime later this summer.
Okay,
So there'll be a new option related to, and a new way that individuals in assisted living have their waiver managed, because it'll be a different waiver.
so it won't be so it'll be they'll have a separate management entity.
Yes. Yes.
Not
And-
Pathways. Boy, I really do have a headache now, but
And I'm aware that there are a lot of meetings and work groups looking at the creation of the application to CMS.
And then the people that are in nursing homes who go in under Pathways currently will roll out after 100 days
My understanding.
into
Fee for service.
and be overseen by. Okay.
I think that's the reason for
Yeah.
going after that waiver.
Before I fall off my chair. Okay, so it's sort of out there. Okay, all right. And then we wonder why the general population doesn't understand what's going on. We really don't have to be this confusing, but we are. Okay, all right. Well, thank you, everyone. Is there anything else we need to bring before us? We're going to be done by noon. Wow, did well. Well, thank you, everyone. We do have a lot of business going on with older adults here. We have a lot of us. So thank you, everyone, for all your service and work. We've got a lot of really hardworking people in Indiana trying to support older adults and their families. And thank you, everyone. And we will reconvene again at our May meeting. So thank you. The meeting is adjourned.